All right. Hello, everybody. My name is Anup Katheria, and I'm a neonatologist here in San Diego. And I apologize for not being able to be there in person today to present this, but I'm looking forward to chatting with you guys virtually afterwards for the Q&A. And my role today is to really give you the evidence for delayed cord clamping and preterm and term newborns. And so I hope by the end of today, you guys will be able to be equipped with the evidence we have so far. I have no conflicts, but I've done a lot of research in this work, so some of it will incorporate some of the grant bodies that have funded our work here. And really, I'm going to sort of break this talk up into 4 parts. I know we only have 30 minutes, but I'll try to review what the evidence is for delayed cord clamping, really focusing on a few impactful trials. There's plenty of studies out there, but I think there's some that have really pushed the needle forward in terms of convincing us that this is a good thing for babies. We'll talk about the concerns. I think that's the biggest point in this talk is what are some of the areas that we're not so comfortable with? The baby who's not breathing well, the tiny baby who's growth restricted. What about those babies in delayed cord clamping? And then we have some data from a few collaborators and I here in California to look at our hospital outcomes, and for you all implementing this in Tennessee, I think it's good to look at it as a state level and different NICUs to look at the impact of outcomes there. And then lastly, I'll talk about resuscitation with an intact cord. Are we really ready to start doing this in babies where we bring the equipment to the OR or by the mother to resuscitate these infants that need it early on? So let's start with some of the evidence. So for preterm babies, the most impactful trial to date is the study conducted out of Australia called the Australian Placental Transfusion Study, a large study of 1,600 babies conducted over several centers all over the world that looked at delayed cord clamping versus immediate cord clamping. And while they had this composite outcome of death or major morbidity that was not different, but they were able to show a difference in death. When you look at their study combined with all the studies shown to date in this meta-analysis, the blue square here is that Australian placental transfusion trial that did show a statistical significant reduction in death. Combining all these together, you can see that delayed cord clamping in preterm babies does reduce mortality. And I think that's point number 1 when we're looking at this intervention for these preterm infants. Now, when we look at some of the data on term and late term infants, we're not going to reduce mortality because most of our term babies survive whether we clamp the cord early or not. So what is the reason to do that in this population? And I think most of the focus in this group has been on blood. Delayed cord clamping does increase your hemoglobin levels in term and preterm babies, as shown by this meta-analysis published last year, that hemoglobin levels, if you look at the means here, were higher in those babies with delayed cord clamping. And the question is that really enough to do so? And when we look at how long to delay and that sort of difference in blood, you can see some work here done by Judith Mercer, showing that immediate cord clamping is shown here by ICC. This is the blood left over in the placenta. And as you can see, as you continue to delay from 2 minutes, as shown here, 5 minutes, or milking the cord, those end up pulling more blood from the placenta and driving that towards the infant. And her group has shown that not only is blood transfer improved, but it actually benefits the baby. And part of this is that increased hemoglobin stores and ferritin levels improve myelination in these term infants. And this is part of their long-term study when they randomized term babies to immediate cord clamping or delayed cord clamping at 12 months and looked at MRIs in these babies. And you can see that the orange areas showed the areas that are different in the babies who received delayed cord clamping compared to immediate cord clamping, showing areas of increased myelination between these different cuts here. And I think part of that suggesting that there is probably a neurodevelopmental benefit in these babies when they're receiving delayed cord clamping at term. Some further work that's taken this a little bit further along is a 4-year outcome study done by the group out in Sweden, led by Ola Andersson, that looked at measurements of fine motor processing speed and the ages and stages questionnaire, looking at differences with delayed cord clamping shown here in the dark circle, the dark bars compared to the lighter bars, which was early cord clamping. And while there was gender differences in boys and girls, you can see that babies or children that had delayed cord clamping, when you look at them as far as their fine motor scores or ABC movements, were definitely having a lower incidence with delayed cord clamping as far as impairment at 4 years of age. So I think this is good data suggesting that in fact, doing delayed cord clamping at birth can help some of these infants have better neurodevelopmental outcomes, or at least reduce the incidence of impairment in these children. So that's some of the data so far that's been shown. Now, when we think about what has to occur for blood to move from the placenta to the infant, I think we have to look at these different factors. And it's important when we think about when we get these babies, what can we do to facilitate babies to receive this additional blood from the placenta? Obviously, one of the biggest driving forces is uterine contraction. That uterus is squeezing down on that placenta, pushing blood out of the placenta towards the newborn. Over here on the bottom left, spasming of the umbilical arteries. The arteries are taking blood from the baby towards the placenta. So after the baby's born, we want that to slow down. So waiting for spasming of umbilical arteries or the lack of pulse is another good telltale sign that net flow is going in towards the baby. We know that negative intrathoracic pressure, as the babies are starting to breathe, that lung bed is now being filled with blood. So getting the baby to take those first few gasps are critical to allow delayed cord clamping to work effectively. And then on the bottom right is intrinsic cardiac activity. The baby's not having a good heart rate. The question of whether or not delayed cord clamping has benefit is questioned. And I think the idea is to allow these things to start to occur while the baby's still connected, receiving this additional blood. So then you get a nice pink baby that's transitioning well. So let's talk about some of these other things, like the babies who are not breathing during delayed cord clamping. Is that a problem? And in fact, it is. This is some data from taken out of Africa by this group that looked at in Tanzania, babies who were not breathing and the onset of breathing timing for the compared to the duration of when the cord is clamped. So if the baby did not breathe for minus, say, 300 seconds, so the baby was born and did not breathe until 300 seconds later, you can see that the incidence of mortality in that population, this is over 12,000 babies, was 3%. As you reduce that duration, or the baby starting to breathe before the cord is clamped, you can see the longer you go here, the more likely that mortality difference drops to almost zero. Now, obviously, this is a retrospective review, so you could see that while the well babies clearly did fine and the babies who weren't breathing did poorly, but it highlights the importance of trying to get the baby to breathe prior to cord clamping, if you can do so. And so that's part of this next sort of discussion here. Some lamb data, again, just to sort of highlight this, is that if you clamp the cord before that infant is breathing, or at least what's shown in a preterm lamb model, that baby will then experience severe bradycardia, decreases in cardiac output, compared to allowing that baby, or lamb in this case, to start to breathe. You get this nice smooth transition of continued stability in heart rate and cardiac output. Now, when we talk about the onset of breathing, it's important to sort of look at the true human experience. So this is a trial where we tried, at least attempted, to ventilate babies while they were still connected to the cord. And these are preterm infants, compared to just trying and stimulating them alone. And the trial, in fact, showed no difference in any of the neonatal outcomes. So hemoglobin levels, IVH and bleeding, all of those were similar across the board. But what we noticed is that while these two groups here, the blue line are the babies who got stimulated and the red line are the babies who were ventilated, that the onset of breathing took time. So that if you look at a baby at 20 seconds, only 40% of those preterm babies were actually starting to make a gasp or breathe. And we had video recordings to sort of document this. At 40 seconds, only 70% of those babies were breathing. And by 60 seconds, 90% of those babies started to breathe. And so it gives you an idea that it takes time. That baby that's a difficult extraction, that baby who's stunned, if they're provided gentle stimulation, they can start to breathe. And there's other data to support this. This is the group out of Nepal that looked at an observational study comparing babies who were just stimulated, that were not breathing at birth, compared to babies who had their cords clamped right away and then were resuscitating. So if you stimulated those babies and got them to breathe before the cord was clamped, these are all depressed babies. They actually were starting to breathe before the cord was clamped. They actually needed less bag mask ventilation in those babies who were stimulated versus clamping right away, had a lower incidence of an APGAR less than 3 at 1 minute. And the odds ratio of breathing, if they were stimulated, was 84% increased in those babies versus clamping right away. So you as a neonatologist or the obstetrician, if you were just providing some stimulation in these babies prior to cord clamping, you're more likely to get a better baby after the cord is clamped versus rushing in there to clamp those cords right away. So hopefully this video will play. This is a baby in one of my trials who was not breathing right away at birth. So this is the control arm. So the baby's placed on this bed. And so, and has some tone a little bit, was moving. So you could argue this baby may have not looked as bad. But after a while, you could see the OB, they're starting to get a little bit nervous because the baby's not starting to breathe. So I'm bulb suctioning the baby, drying the baby off. And again, while I'm a neonatologist doing this, you could easily see the provider doing that. So he's grabbing the hemostat, which they always start to do, and he's getting close to the core there. I'm just going to keep stimulating the baby. Now listen for the cry. Right there. So it took about 50 seconds there. And that's a long time to wait. But again, you're providing this baby's on a placental bypass circuit, getting oxygen from the placenta. The baby's not asphyxiated. He's not laying there floppy, looking like he's suffered a hit from HIE. Most preterm babies are actually quite well. They're not babies who've been deprived of oxygen for some period of time in the womb. And so allowing that baby to start to try to transition is probably the best thing we can do for these infants. So getting into some of our own practices here, this is a survey that I did with a couple of collaborators out of Texas, looking at some responses from 77 NICUs using the AAP collaborative. And you can see here that really there's a vast majority, almost half people, no matter how many years you're in practice, whether you're in a teaching hospital or not, whether you're in a level 1, 2, 3, 4 NICU, a lot of these people, at least half or not greater, are not practicing delayed cord clamping, meaning their routine practice is to clamp the cord before 60 seconds. And there's not much of a regional variation either. It's not being out here in California, we're any different than being out in the South or Midwest. Now, we looked at our own data here in California as part of a collaborative, just like you have in Tennessee, to look at the hospital level, are there differences in delayed cord clamping rates and individual outcomes compared to hospital outcomes? So we had a huge number in our CPQCC database as part of this collaborative where we said, we're going to implement delayed cord clamping and look at how it impacts our NICU. So of these 60,000 babies, we excluded any babies that were born before implementation of this delayed cord clamping protocol and just looked at the babies who had delayed clamping or not. We excluded the ones that received cord milking or who died in the delivery room and had 13,000 babies to look at. And we compared the ones that did not get delayed cord clamping, which were around 7,000, compared to the ones that did for at least 30 seconds or about 1,500 babies. Now, when we looked at this data and compared groups here, and I just made it into a bar graph just to show you at the end of the day, no matter what birth weight you were, gestational age, gender, there was really not any major differences on delayed cord clamping in those outcomes. Now, when you look at outcomes after cord clamping, like APGARs, those might have been different, but virtually the rest of the outcomes were essentially the same. And then when you look at death in sort of the hospital level, you can sort of see a trend here that the rate of delayed cord clamping as it sort of increased here, mortality sort of drops. So you can see a high numbers up here in the top left. And by the time you're getting to these NICUs that implement delayed cord clamping around 75% or greater, their mortality rate is extremely low. And this is like less than 5% compared to those who not. And again, it's important to also note that these circles, community, intermediate, regional, or what we have non-CCS or California Children's Services hospitals, it didn't matter. They all sort of had this net benefit as you sort of move down the rate over here. Now, when we did some analysis looking at risk ratios, adjusted and unadjusted, adjusting for things like prematurity, et cetera, you could see here that at the individual level, the babies born at these hospitals, that was decreased mortality and severe IVH, things that we know delayed cord clamping can have. But what I thought was most interesting is that at the hospital level, because this is an important regional meeting that we're having here, at the hospital level, for every 10%, you're able to reduce the rates of your delayed cord clamping or increase delayed cord clamping in your NICU, you reduce mortality by 5%. And so it's not much to take a unit to go from 50 to 60% or 60 to 70. We're just talking about implementing some guidelines between the obstetricians and neonatologists, but reducing mortality. And that's a huge outcome that we could all strive to achieve with something that's really quite simple. Okay, so a couple other things just to sort of discuss here that are of concern. One of the big ones I often hear are babies who are severe IUGR, the placenta has abnormal Dopplers. Is there any value in doing delayed cord clamping in those infants? And the answer is absolutely yes. This is a study that reduced necrotizing enterocolitis, or at least suspected necrotizing enterocolitis in those babies that received delayed cord clamping compared to immediate cord clamping. So that IUGR infant, that placenta is not working great, it makes sense to at least allow that baby to start to breathe and transition So that way that heart that has to be exposed to that high afterload placenta doesn't have to deal with an even higher afterload by clamping the cord early. It could actually benefit from having a transition before that cord is clamped and perfusing organs like the gut, et cetera. So you don't have that morbidity of things like necrotizing enterocolitis. The other big one we hear a lot about is hyperbilirubinemia. These babies can get jaundiced, and the latest meta-analysis shows while there's not a difference, showing the diamond here is crossing one between babies that needed phototherapy or not, I think it's important to realize, yeah, maybe delayed cord clamping does increase your bilirubin levels. And there have been some studies that have showed benefits, or not benefits, but increased bilirubin levels, and others that haven't. But I sort of want to own up to the fact that if delayed cord clamping increases your bilirubin, is that a horrible thing? We have phototherapy, but even is bilirubin itself potentially something beneficial? And there's some great work by Kathy Hammerman, who's out in Israel, demonstrating that bilirubin actually acts as an antioxidant for these babies, and probably even more for preterm babies that are subject to all these areas of oxidative stress and morbidities like ROP or chronic lung disease. Would it be okay to have extra antioxidant in your body if that's how bilirubin works? And so she looked at measurements of comparing bilirubin levels to TAA levels, which is a measure of antioxidant activity, and showed, in fact, there's a nice correlation as your bilirubin is higher that you have higher levels of antioxidant capacity. But more importantly, when you look at some of the clinical scenarios, this is some additional work that she's presented before, showing here in red, these are the babies with HIE in the unit and having extremely low bilirubin levels compared to the normogram data. And so I think it's important. And after I heard this first presentation from her, I realized that the babies who are actually the sickest from HIE never go on phototherapy because they've used up all that antioxidant capability from their bilirubin. So it's sucked up and they have nothing left. And so for us to say jaundice could be a harmful thing, of course, if it's at high levels, it could be harmful. But if we're monitoring it and we give these babies some extra bilirubin, that may not be a horrible thing for these infants. This is also some work out of China. This looked at over 144 babies that had HIE, no HIE compared to controls. And you can see here that babies who had no HA, when they sampled bilirubins, and they sampled them quite frequently, these are serum levels, and the normal babies are much, much higher than babies who had HIE in their group. And more importantly, when you took the bilirubin level and compared it to long-term outcomes, you can see here that the Bailey 3 motor composite score was highest in the babies with the highest bilirubin concentration. Now, these weren't high levels like in the 20s where you could get kernicterus, but just higher levels. And so this may not be a terrible thing for babies to experience a slightly higher bilirubin level. Now, so to kind of talk about delayed cord clamping, we know that, again, there's these benefits for term and preterm babies. Yes, there might be side effects of increased bilirubin in these babies, but that might actually be physiological. And when you look at the real benefits of improved neurodevelopmental outcomes in term babies, improved survival in preterm babies, I think these clearly outweigh the potential risks of benefit in hyperbilirubinemia. Of course, if we didn't have access to phototherapy or measuring things, it could theoretically be there in those babies that might have another reason to raise their bilirubin or an undiagnosed conjugation defect. But for the most part, we're trying to talk about morbidities that are so important to us. And at a hospital level, reducing things like mortalities always should be a goal for all of our patients. And I really like the work that Scott's been doing with your group in Tennessee, looking at terms such as optimal cord clamping. Let's get away with using something that has a negative connotation like delayed cord clamping. So you can change the terminology, talk about that you're actively providing a therapy. You're not delaying anything. You're giving them that sort of first initial therapy before anything else comes down the line. So the last part, I just wanted to talk about where this whole thing is going. And of course, ACOG has come out with this area of future research, looking at those babies that truly need resuscitation, those asphyxiated babies, depressed babies that they're not going to respond to stimulation no matter what you do. Is there a benefit of doing things like resuscitating them while they're connected to the cord, milking the cord? Those are other therapies that are still being looked at. I'm not going to talk about milking the cord, although we're conducting a large randomized controlled trial comparing milking to early cord clamping, but I did want to talk a little bit about resuscitation with an intact cord. And then getting back to this diagram we talked about earlier, we know that when you have a baby who's depressed, now you have this difference of trying to move the baby quickly to the neonatal resuscitation team. So the OB team is going to quickly move the baby over to us, and this is going to truncate that normal redistribution of blood that would come from the placenta to the newborn infant. And we look at these factors, many of them are modified here. For instance, when we have an urgent C-section, we cut through the placenta. So we don't have the benefit of that uterine squeeze on the placenta. And we see this more commonly in not just emergent C-sections, but even our extremely preterm infants. Many of them have to be delivered by C-section due to maternal indications or something else going wrong. When we think about that umbilical artery spasming to put the brakes on blood flowing out of the baby, we have challenges like cord compression. When you have a nuchal cord wrapped around the baby's head, that thin-walled umbilical vein gets squeezed, so you don't get blood flowing into the baby, but that thick muscular umbilical artery stays open. So now the blood is actually pouring out of the baby into the placenta while that cord is wrapped around the neck. Other areas that are affected, if you have babies who are apneic or they're not breathing well, extreme prematurity, those are all areas where that baby may not breathing effectively, so you don't get that lung to sort of open up. And I mentioned earlier, if you have severe bradycardia or asystole, there's any question whether those babies can actually get any blood in there because you're not having that cardiac pump. So in these cases, we may get the baby faster, but now we have a baby with relative hypovolemia. And so we, as well as many others, have been looking at the area of resuscitation with the intact cord. This is another baby on that sort of same trial. And here you can see the baby's actually going to get resuscitation with an intact cord. So after we dry and stimulate the baby there, we're going to place a mask on the baby's face while the baby's still connected to the placenta and provide some CPAP and respiratory support to that infant. And we did that for a full minute. And as I told you, this didn't make no difference in their outcomes when we looked at the two, but we just looked at the onset of breathing between the two arms. So just to give you a quick overview, this is from a paper that's coming out in Neo Reviews in the next few months, looking at resuscitation within the intact cord. There's all kinds of devices out there. I'm not going to get into all of them, but the idea is to bring as much equipment as you could to the bedside. Again, how do you bring in other monitors and things of that nature? We're still trying to work those things out. But these are some of the other devices that are currently being looked at. Unfortunately, most of them are not available here in the United States. Only one of them is currently FDA approved, but you might see more of these coming out sort of in the next several years probably. And they're all currently just being used in research purposes mostly. And this, the top left, just shows you the setup at vaginal delivery compared to C-section, that you're trying to get additional providers in here, which again can be a challenge. I think sort of my next slide here, getting into sort of the pros and cons, doing delayed cord clamping with resuscitation. And I didn't spend too much time on this topic, but the green are really the big benefits here. Most of the trials have shown that it's physiologic, better heart rate, saturation in the baby, et cetera. And the parents, when you survey them, they actually like it more to be able to see their baby and be able to touch their baby during resuscitation. So some surveys completed by our group as well as a group in England. There are a lot of challenges though. Challenge with the cord length, getting good data on maternal safety, doing prolonged delayed cord clamping at C-section, a compromised resuscitation when you don't have ECG monitoring or pulse oximetry. And also there's limited space for the other staffing. You aren't able to really get a neonatologist with a nurse and a respiratory therapist in here because you have several OBs, an OR tech, and you're trying to get in this crowded space here at C-section, or even a vaginal delivery where there's minimal room between the mother's legs and the baby in the bed right there, trying to resuscitate the infant. So those are things that we still need to work on before we sort of implement this as far as mainstream. And then the question of, do all babies need resuscitation? Even those preterm babies, can they sort of auto-resus? And actually, if you give them time and stimulation, they might start to pick up. And we may not necessarily need all of this. And maybe this is reserved for just those really, really bad babies that might be asphyxiated. So to sort of wrap up this part, is just that, resuscitation within an intact cord might have some benefits physiologically. None of the trials, and again, I could spend a lot of time talking about this, reviewing the evidence, have shown any clinical benefit that's been definitive. So there still needs to be more area of research there. And I think we need to do studies comparing true delayed cord clamping with stimulation and trying to go as long as we can to a group of babies who get oxygen and CPAP and those sorts of things to see whether or not we really should be implementing this in all of our NICUs. It's quite expensive. There's a lot of work and logistics that go into these. Again, we're using it right now, even currently as part of a trial. They're not easy to do. My colleagues always much rather just do delayed cord clamping than doing this. And so we need to find the right group that actually can benefit this before we implement this throughout. So just in closing, I have so many people that I get to work with as part of these cord clamping trials, OBs and neonatologists from all over the world. It's been a huge pleasure. These are just their photos that have really helped get our work out there on both milking and delayed cord clamping and resuscitation with an intact cord. And then my research team over here in San Diego could not have done any of this without their work as well. So thank you. And when I go live, hope you'll be able to answer some questions. And special thanks to just Anup Katheria and his team for allowing me to come present to you guys today.